Good morning, good morning, good morning. And it is December, and it's not that bad outside. Welcome to the Great Lakes Health Radio program on Power 96.5 FM, WUFO 1080 AM, where every other Saturday, every second and fourth Saturday, you will learn about uh, the inside of Kaleida Health System, the multifaceted healthcare, largest healthcare system in Western New York. My name is Francesca Messiah, Manager of Workforce Development at Kaleida Health. Kaleida, we are the hospitals. So in Buffalo and the immediate area, we are Buffalo General Medical Center. We are Gates Vascular Institute, Oshai Children's Hospital. We also are Millard Fillmore Suburban. We have two long-term care facilities. One, High Point, and High Point is at High and Michigan Avenue, and DeGraff Skilled Nursing Facility in North Tonawanda. We have clinics throughout the area for all ages, for children, for adults, for moms. But to find out more about Kaleida Health, please visit our website at www.Kaleida Health. That is www.kaleidahealth.org. And let me spell Kaleida for you. KALEIDAHEALTH.org. And while you're on our website, reviewing our hospitals and clinics, please don't forget about our career section. So in the search engine, put in Kaleida Health careers, because we have over 900 positions and we need you to work for us. Well, our topics for today, our topics and our guests for today. Our first guest is Melissa Wanzer, and Melissa is a dear friend, and she is manager of survivorship and supportive services and she will tell us about Glenn, and that's the name of another division within Kaleida Health, and our topic is going to begin as we begin the new year, why screenings are so important, especially for adults, especially for adults. That's what we're going to be talking about, cancer screenings. And our second guest, another very dear friend of mine, for the past 20 years, I've been at Kaleida for 20 years, and that is Michael P. Hughes. He will be on the second half of the program, beginning at 7:30. And Mike Hughes is the chief of staff for Kaleida Health, and he has a very exciting story. And he's also getting ready to leave cancer. He's getting ready to leave Kaleida Health, and so, but that we'll talk more about that in our second half hour. But Melissa, how are you today?
I'm wonderful. Thank you for having me, Francesca.
Yeah. Melissa, a few weeks ago at Passport to Wellness, I observed you and your colleague talking to participants of Passport to Wellness at the Broadway Market. And you were talking to them about the importance of cancer screenings. And I was watching how attentive everyone was listening to you. And when I asked everybody what was one thing that they recall from meeting with like all 12 or 15 wellness vendors, and one of the number one things they said was getting screenings for cancer. So my first question, why are cancer screenings so important?
Well, thankfully, there will be more cancer survivors, each year. And I think in 2022 was estimated like 18 million cancer survivors in the United States. And a big part of that increase, that significant bump in survivorship, is improvements in prevention. Thankfully, we know how to do some things to prevent cancer, screening, obviously, which I'm going to talk about, and then early detection and treatment. So all of these things have, all four of these things, prevention, screening, earlier diagnosis, and improvement in treatments, have have increased the number of individuals who are surviving and living beyond a cancer diagnosis. So, screening, the key here is that going to get screened, meeting these age requirements, these specific age requirements allows us to catch cancer early. And the earlier that you catch it, right, the more successful the treatment can be. So stated simply, catching it early, getting it as quickly as possible, identifying what type of cancer it is, and then setting up a treatment plan leads to greater outcomes.
Yeah, thank you. And I wanted to say to our listeners, please do not be afraid to get screened. We'll talk more. We'll talk more about that. So before, when Kaleida Health first established their cancer division, it was past tense. It was called the Great Lakes Health Cancer Care Collaboration. This concept is we're no longer using this name. We're now with Glenn, and that's what I need you to briefly describe. We're still doing the same services, just a different name. The players are the
Well,
same. Could you
yeah,
just
let me clarify that, because I think that the important clarification is that my team, okay, so my team, which is supportive services, so I'm part of the supportive services team. My team moved to Glenn. So Glenn IPA is Western New York's leading clinical integrated network. They partner with facilities and independent healthcare providers in the community, and they work together to improve patient experiences, improve population health, and lower the cost of healthcare. Well, all of those things are applicable to oncology patients. So Glenn IPA connects patients to a primary care provider. I mean, patients need a primary care provider because that's the one who's going to talk to them about screenings, who's going to create the referrals for them to get screened. So we know how important that is. Our team, right? My team, my boss, Michelle Hubert Fiskus, our nutritionist, our nurse navigators, our screening navigator, our quality person, our cancer tumor register. My team now lives is moved to Glenn IPA. And there we are part of the oncology support services team. So, we provide services for patients, oncology patients who are going to ECMC, Buffalo General Medical Center, Millard Fillmore Suburban, who are seen at GPPC, Cancer Care of Western New York, and Western New York Urology. So all of those facilities, all of those entities treat cancer patients. They all take care of cancer patients. And so our team provides supportive services for all of those organizations.
thank you. And you know what, Melissa, I'm just going to say right now, in case we run out of time, because to me, this interview, like all interviews, are extremely important. We're going to have another program. I just want to let you know. So, how about street?
I always love talking to you, Francesca. So
Oh, I know we have fun. We really do. Well, you know what? Oh, I get so I get like flustered with cancer, having had a sister pass from cancer, and someone recently was caught early. So sometimes I just have to take a breath during interviews around cancer. How can listeners learn more about screenings and are they eligible and the screenings that they're eligible to receive? And what I mean by that, so let's say you are 38 years old and your mother, and your grandmother and or your grandmother has had breast cancer, ovarian cancer, and your father or your grandfather on your mother's side of the family has had prostate cancer, colon cancer. You're 38 years old. And what if you don't meet some of the guidelines? But and let's say a couple of your cousins have cancer, and on paper it's saying you're not young enough. What what should someone do in that case about the
right. So
screenings?
that's an excellent point, Francesca, because first of all, this is why sharing your health history, right? So I mentioned this, having a primary care provider, which is one of the questions I ask every single person right, at the Broadway Market event, right? Do you have a primary care provider? I remember one of our doctors called the primary care provider the quarterback of your health, right? And that is the quarterback of your health, that it starts with having a primary care provider. And you and I have talked about this at length, right? That patients need to share their health history. They need to first of all, they need to know their health history.
Right. Yes. Yes.
They need to know it, and they need to get that information from their family and make sure it's accurate. And then they share that with their primary care provider. And then hopefully that primary care provider will say, okay, you have a significant history of cancer in your family. So instead of, for example, breast cancer screening, which typically starts at 40, we're going to start you younger, right? We're going to start you earlier. So I'll use my own example. As someone who had breast cancer, both of my sisters are getting screened for breast cancer younger than 40, right? So they both shared it with their providers. They're in two different parts of Pennsylvania, and both of their providers said, yep, you're going to start getting screened for breast cancer. So they also shared, the dense breast history and things like that. So they're getting additional screening beyond the mammogram. That's important. I can't emphasize that enough for women. If you've been identified as having dense breast tissue, you should be getting a secondary screening test, and that's ultrasound to look deeper into what's going on in your breast. But I think that's essential. Sharing that health history, to go back to that point, sharing that health history with your primary care provider, making sure that that information is current and up to date. And then, your example, right, of somebody who's 38, technically on paper, they don't qualify, right, for
Right.
colorectal screening because it starts at 45. But we know that African Americans are more at risk for early onset of colorectal cancer. And so, if that person, and many of them said, I'm too young, right? I mean, when I talked to them at the Broadway Market, well, I'm 35. Then my next question is, do you have a family history of colorectal cancer? Make sure you share that with your primary care doctor. And you may be getting, unfortunately, right, you might be getting a colonoscopy much younger than 45. I wouldn't be surprised if we talk about this, if that age, that colorectal screening age, even drops younger than 45 because of
Mhm.
the significant increase in young people who are presenting with colorectal cancer. I think these screening guidelines are, they're numbers to use, but they definitely are variable, right? Because if you have a family history of cancer, your provider should probably be sending you for screening tests earlier.
Yeah. And also something, if you're listening right now, throwing your hands up in the air thinking, how can I find my history? You can ask your family members about their history, but you can't ask their physician because that's violation of HIPAA law. But for your history, you can go to your provider and get copies of your medical information, because we are not expecting you to remember everything your physician has shared with you, but the information should be documented so then you can get a copy of that and begin understanding and asking your primary care physician questions about your history. I just wanted to add that. Um, our,
And that's a great point.
Mhm.
I think that's a wonderful suggestion because I know I talk to patients all the time, and I'll ask them questions about their cancer history, and many of them, I'm not sure, I don't know, you know, that's why getting that health history, and even with our patients, they meet with our APP, our survivorship APP, and they have a survivorship visit.
What's APP?
I'm sorry, advanced practice practitioner.
Okay,
Um,
thank you.
so PA, nurse practitioner. So they meet with her, and she prints out what's called a survivorship care plan. And that survivorship care plan includes a treatment summary. So your diagnosis, the treatments you received, the doctors that did the treatments, and then that's part one of the survivorship care plan. And then the second part is your plan for, what next, right? So what they're going to do to make sure, reduce the risk of your cancer coming back.
Mm. Yeah, no, thank you. And if you misplace that, you go right back, call them. I'm sure
That's
you
right.
you can get another copy. It's not a one and done for the copies. Now, something that we talked about, you talked about African Americans being at greater risk for colorectal cancer. Are there any other cancers that you see, not that you, but that research has proven, data has proven African Americans are at greater risk?
Well, off the top of my head, the the one
We
thing that
hear
comes to my
prostate.
mind.
I'll just say we hear about prostate a lot. Black men, dying of that, not getting. But again, if you go back to not getting screened, and breast cancer for African American women.
Right. So I can speak a little bit more at length about breast cancer specifically. So while African American women do not have a higher rate of breast cancer, right? Specifically, like they are not getting breast cancer more frequently. They are more at risk for certain types of breast cancer. So breast cancer is an incredibly complex type of cancer in that when you get breast cancer, there are a million questions that people ask. What type is it? Is it ductal? Is it lobular? What's the name of it? Is it invasive? Is it non-invasive? Is it what stage is it? And then what's the ER/PR HER2 status? African American women, as my understanding, the most recent things that I've read, are more at risk for what's called triple negative. So triple negative breast cancer means that it's ER/PR negative and HER2 negative. And that is a more aggressive form of cancer. So there's that they're more at risk for that specific type, and that it is typically caught later. So those are two things that might lead to a higher mortality rate in African American women. And again, they're not necessarily getting breast cancer more often than other races or ethnicities, but they're more at risk for triple negative. And then if it's caught later, right, in a more advanced stage, it's more challenging to treat. So those are the two things that might lead to that higher mortality rate. So going back to what we've been saying, getting screened, knowing your health history, right? If African American women have a health history of breast cancer and specifically triple negative, that information needs to be shared with their OBGYN, their primary care, so that they can start screening earlier.
Yeah, and thank you because everyone was. I remember when my sister, passed away. Like, well, what kind of breast cancer? That had to be the most confusing, complicated question because I had no idea, and they don't talk about that. And they talk about so that's the importance again of getting screened, ladies, for breast cancer. And if you know you have an appointment coming up, bring a friend, but let that friend know at least a week or two in advance if you can go with them, if they can go with you. Sorry, and that's okay. It's just bringing a buddy, and ask them whether they need a breast examination and see, and maybe the two of you can get it done at the same time. That's just a sidebar. Sorry. Um, Melissa, so if a family member has cancer, um, where what are the next steps? Like who makes that diagnosis? Is it the primary care, or how does that diagnosis? Who's responsible at Glenn for making? Where does that come from?
Well, as we said, right, I keep going back to the primary care doctor, right, who's kind of
The
the quarterback,
quarterback, the
right?
quarterback,
I mean, the Josh Allen, right? Let's make
right?
it more right, the Josh Allen. And we hope we have a primary care doctor that's comparable to Josh Allen, right? Um, so, the primary care doctor is the one who is, again, kind of starting the process of, getting you screened. And just to clarify, right, like what a screening test is, right? So a screening test is getting tested when there are no symptoms, right? And so it's kind of interesting, Francesca, like this is a little sidebar. Like when you feel fine, right, you don't think, you know what I want to do? I want to go to the doctor, right? because you feel fine. But that's really what you're doing when you have a screening test, right? There are no symptoms, there's nothing going on. So encouraging people to go and have a test and maybe pay a copay and drive and take off work, right? Like, I get it. I understand why some people push back, but the return on that investment is substantial, right? If you go in and have that screening test and you don't have any signs and symptoms, but something is caught very early, that's a really good thing, right? That's a really good thing. So when your primary care doctor says to you, hey, go get your colonoscopy. Hey, I see you're a smoker, right? You're age 50 to 80. You meet the 20 pack rule. I need you to go get a low dose CT scan, right? When your primary care doctor sends you to get that test, step one is going to get it, right? You go to get it because you go to wherever imaging they recommend or wherever you go regularly to get your imaging done. And then that's where it starts, right? They look at your imaging, they determine whether there's something there. And then part of that process is then probably more screening, right? It could be blood work, it could be additional imaging, those kind of things. And then that information then goes back, right, to your primary care doctor. And then your primary care doctor reaches out and says, hey, unfortunately, we found something, and then makes recommendations, right? And says, okay, because the first question that a patient asks is what's next, right? Where do I go? And so that primary care, that quarterback is going to say, okay, here are some names. Here's who I recommend. This would be the next step, meeting with a surgeon, right? After you meet with that surgeon, right? Meeting with an oncologist. And so there are many, and this is what patients say, they're so overwhelmed in the beginning because there's so many appointments and steps that you have to take before you can even start your treatment, because the care team is trying to make a determination of, what's the best treatment, what's the pathology say. They're making sure the pathology is accurate. So there's a lot that goes on, and it can be very tiring and very frustrating, I think, because there's so much behind the scenes work, but that's important work because you want everything to be, you want the treatment to be the right treatment.
Yeah, and I have to say, you just mentioned something very important. I was speaking with a close friend of the family who has just finished a round of cancer treatment, cancer free, and he went in when he had no symptoms, and and just saying how happy he had his quarterback, right? But what he said, I asked him what one of the most important things for the show. He said having your team around you. So you have a team, and as the patient, please develop your team. Your team are your friends, your church friends, they're your family. You don't have to include everybody, but you are not, if you have been diagnosed with cancer, this isn't an island. You are not on it. You're not the only one. Bring those who are close to you
Right. And,
into what
yep.
again, I go back to family. My family member only brought a couple of people closer, and I respect that. You don't have to let everybody know, because there are some people who will treat you differently. I'm not going to say they're not. So bring those who you're comfortable with into your circle, and so you're not and take them to your appointments with you. There's a team on the Glen side. There should be a team on your side. That's all I'm saying. Michelle, I'm not Michelle, sorry, Melissa, we are going to have a second part because we only have a couple minutes left. But let's how about, what are some of the frequently asked questions when people come to see you on cancer?
Well, I think for me personally, when I talk to our patients, um, I think that the most working in survivorship, right? So working in survivorship and helping people live beyond their cancer diagnosis. What can I do to stay healthy, right? What can I do to reduce my recurrence and stay healthy? And Number one, I'm going to say this, and I know it's not going to come as a shock, exercise.
Mm.
Exercise. That's number one. And I feel like I'm going to put up a billboard, make sure it's, 150 minutes a week. And, just really make that part of your lifestyle. I was we had an event on Wednesday, Tuesday, I think, with Kelly Cardamone, who's a nutritionist, and she talked about, what to eat. But her talk integrated exercise the entire time. So obviously her number one thing, I can sum up her lecture, her 50, 60-minute lecture, 5 fruits and vegetables, 150 exercise. If you can just do those two things alone are huge factors in your staying healthy. So 5 fruits and vegetables, 150 minutes a week of exercise.
And I know, and we're going to close it out. But if Kelly Cardamone's name sounds familiar, listeners, it's because I've had her on the program each year, anywhere between on the average of 4 times, talking about eating, about nutrition. And I have to say, she's now my nutritionist. But I'm sorry that I missed that program. Um, we have about a minute left. So and this is part one. Part two, life beyond beyond living beyond survivorship will be something along those lines for our next show. Closing comments for you, Melissa.
Well, again, I hope everyone has a happy holiday, and wish everyone a healthy and happy holiday. But I encourage you to start with the new year, right? If that's a good time to integrate regular exercise, and go for that, set a goal, 150 minutes a week, right? You know, 30 minutes a day, 20, 30 minutes a day, walking, anything, right? You don't have to go to the gym, and try to get those 5 servings of fruits and vegetables. I think that's the best thing that we can do for ourselves. And getting screened. I'm sorry. And
Yes,
going
yes,
for your
getting
screening. Yep. Getting
and
screened. Sorry.
get getting screened. And I tell you, and as we speak, I'm drinking a vanilla protein shake recommendation from Kelly because I need more protein, and I just add a few frozen strawberries and an ice cube to it. It's vanilla, and so food is so important. That's a whole nother topic. That's a question that we will get to next time. But Melissa, I just want to thank you. Happy holidays. Melissa Wanzer, Manager of Survivorship and Supportive Services. When we're talking about cancer, this interview has been about beginning the new year with $1 million. You know what $1 million is? Getting screened and
Very
getting your
helpful.
screening, right?
Yeah.
Melissa, you want $1 million?
Absolutely.
Absolutely. Well, thank you so much, Melissa. And listeners, stay tuned. Our next guest is Michael P. Hughes, Chief of Staff at Kaleida Health. And now on to part two. Welcome back to the second half of the Great Lakes Health Radio program on Power 96.5 FM and 1080 AM WFO. Well, like I said, to the second half of the program, you know what? They say you're not supposed to have favorites, right? But I can say I do have a very favorite person at Kaleida Health who my 20 years that I've been there, he's also been there. And our guest for today is Michael P. Hughes, Chief Administrative Officer at Kaleida Health. And our topic, Mike is getting ready to leave. Kaleida, I know we will be seeing his name doing great things because Mike only does great things. Mike only associates himself with great things. And we're going to be talking about his legacy. Good morning, Mike. How are you?
Morning, Fran. I'm doing great. Thanks for having me this morning. I always love having a chance to sit and talk with you and to catch up.
Oh, yes, likewise. Well, Michael is his full name, but everyone calls him Mike. And he tells everyone, call me Mike. I've learned so many things from Mike, but you know what? This interview isn't about me. It's about you, Mike. So I'm just so excited that you were able to take time from your hectic schedule as you wind down. What is it? How many years have you been with Kaleida?
Just finished up year 20.
Year 20, yes. And Mike, we only have a half hour. So I just want to jump right into the interview and ask, what changes have you observed in healthcare over the past 20 years? And before this, I know you were with one of the ambulance company. I forgot the name of it. Um, I'm not sure if it has the same name, but you've been in healthcare your career has been in healthcare, not 20 at Kaleida, but overall, how many years have you worked in
25
healthcare?
years, yeah. Prior to joining Kaleida Health, I was with Rural Metro Ambulance, and now it's called AMR,
Mhm.
headquartered here in Buffalo, but covered all of upstate New York. Yeah, so 25 years in healthcare, and certainly seen a lot of change over the years in terms of the advancement of medicine and the ability to take care of patients quicker and get them healing faster from the clinical side. But I think more than anything, what hasn't changed is people's commitment to healthcare, and whether that's the frontline staff, the nurses at the bedside, the commitment to care, and for organizations like Kaleida Health to know the importance that we have in the community and the need to take care of our community. And it's a pretty humbling, opportunity to be part of something like that.
You know what? You just mentioned talking about medicine and healthcare, and I know I'm in a lot of meetings. You're in a lot of meetings, and I know that I'm just going to say when you talk about the advancement in healthcare. What's one example that you would say that really stands out? In my mind, in my 20 years, I would say stroke and how we look at strokes. And what is something you've actually seen that's GBI? So what are some of the advancements that you've actually witnessed in terms of change in healthcare?
Yeah, yeah, to your point. So let's say the Gates Vascular Institute, the stroke care that occurs here, the cardiac, the vascular care. When I was with the ambulance service and first joined Kaleida Health, when it came to neurosurgical care or the stroke program, that was at Millard Fillmore Hospital up at Gates Circle there. They were doing very, very invasive surgery for when patients came in with a stroke. And that was, they would get into patients' skulls, but they did it in a very invasive way. Now, that entire spectrum has changed. Maybe 5 to 10% of that care is done invasively, and the majority of it's done through catheters. So to know that, patients have, a higher likelihood of success and outcome, and there's a quicker, faster way to take care of them is pretty amazing when you think about it. Same thing with cardiac care. I mean, there's ability for the paramedics out in the field to scan a patient and to know exactly what's happening, and our emergency room staff will have that report, while they're in the ambulance, and know what's happening as they come into the emergency room. So I think care and access to care has gotten quicker, stronger, faster. That's a testament to, really the workforce who are committed to, making things better for our patients every day.
Yeah, absolutely. And Mike, could you just talk a little bit about Gates Vascular Institute? During the first half hour, first part of the program, I always talk about the different sites, and I talk about Gates Vascular. But tell our listeners what is unique about Gates Vascular Institute.
Yeah, so, again, back when I first joined Kaleida Health, the vascular world and the different components to it really were isolated. So the cardiac surgeons lived in their world, the cardiologists lived in their world, the neurosurgeons, those who took care of stroke patients lived in their world, and that was everything from different departments to different areas of an operating department that they would work out of. And the whole idea of the Vascular Institute was to bring all those disciplines together. Those who took care of the human body's vascular highway, collisions, as Dr. Hopkins would refer to it. So, where a a physician who may be working on a stroke patient, may need help from the cardiologist or a cardiac surgeon. And, bringing those disciplines together really has helped, transform care, not only here in Western New York, but really the world. There's physicians that come from all over the world, not just the United States, to be trained here in Buffalo to learn what we're doing when it comes to cutting edge stroke care, cardiac surgery, vascular surgery. So it's a really unique idea. Yes, it's a physical location, but really it's a different way to take care of patients.
Mhm. And I just want our listeners to know the reason I'm asking Mike these questions, because Mike has been part of the process of the whole building, what's inside the conversation. So that's why I wanted him to talk about it. Patient population. I know that I've always heard, patients have gotten sicker. Well, patients have always been sick when they come into the hospital. How have you observed how the patient population has changed?
Yeah, I mean, I try to explain to people, nobody wakes up and wants to come to the hospital. A hospital visit, an emergency, it can be a pretty traumatic situation. And whether that's something as simple as, a cough or cold, or someone that's suffering from pneumonia, to someone that has a sudden stroke or cardiac episode. So I think, statistics would show you there's some areas of our population in Western New York that have gotten sicker. But on the flip side, access to care has gotten better. Treatments have gotten better. So patients who, 15, 20 years ago had significant ailments, and that could be any type of surgical procedure or stroke or cardiac episode, they are getting better treatment, but based on technology and medicine. They're getting access to care quicker, and that's, connecting with our EMS community and just the way that emergency rooms are designed. So in some sense, yes, patient population has gotten sicker, but that's modern medicine. The patient population, people are living longer. So naturally, you're going to have people who end up a little bit sicker. But for those who do come through our facilities, I think you would see, over my course of time, just the treatments available are really remarkable. They're second to none.
Hmm. And when you talk about access to care, I mean, do you mean that we have, or better care, access to care? We have more locations throughout Western New York. Could you just
Yeah. So when I started at Kaleida, we had 5 physical hospitals in it. We had a very small ambulatory footprint. You look now, we have hospitals from the city of Buffalo down through the Pennsylvania line. And we have, probably 100 ambulatory sites, and that could be a physician office, that can be an ambulatory location where people are getting access to care and they're in and out in a couple hours. That could be our ambulatory surgery site. So the move to the outpatient space is real. People want to get home quicker, faster. So when you talk about that, and you add that to your first question, or the question before that about the patient population, those who remain in our hospitals usually are there for a few days, and that's because what they're faced with. But I think it's remarkable to see the growth of our organization into the community and really trying to meet the patients where they are.
hmm And now you talk about patients getting home quicker, and you are the chief administrative officer. Where do these decisions, like, how do you, is it from looking at data that a committee comes together to review and then begins to make decisions on, patients wanting to come home quicker? Is that from the survey? You just mentioned 100 ambulatory sites. How do you know where to put the sites? How do you know patients want to come home quicker? Is this data driven?
Yeah, it's a combination. So it is data driven. So in terms of population, right? So you look at the North Towns, the Williamsville, Clarence area, and the growth of those communities over the past 2 decades. You look at resurgence of people coming back downtown, the people that are, from 25 to say 40 that are living in the downtown area of the city of Buffalo. That's following the data, but, more than anything, we are clinically led. So decisions that we may make in terms of specific services that we offer in the inpatient or outpatient setting really are physician driven. And the Vascular Institute is a great example of that. That was a physician-led process. Is a committee of doctors from various disciplines that came together and worked over the course of about 2.5, maybe 3 years, from taking that vision and making it into a full entity of a world-class center. So yeah, it's data plus clinically led.
Mm-hmm. Um, the community. Now, that's one of my number one loves. It's work that I've been doing closely for the past 20 years, working with many of the communities throughout Western New York, but especially within the African American, Latino, and new immigrant community. But what is the role of Kaleida in the Western New York community? I look at things like now talk about what we have, Josh Allen doing things with the Children's Hospital, but we're also meeting with ministers. Let's just talk about the role of Kaleida and the community.
Yeah, from a high level perspective, you look at what our mission is, and that's to advance the health of the community. And that means a number of things. That is making sure that, we're taking care of our patients, that either they come through our emergency room or they have a doctor visit or they have, say a surgical procedure. So, there is the day-to-day taking care of patients. But, there's more of a moral vision that we have, and that we have tried to work on to make sure that we're taking care of our community. Collide is a large organization. We have a large economic impact. So that's making sure that we have, that we buy goods and services from local communities, that we are interfacing with, our neighbors, and whether that's, the faith-based community in and around Buffalo General, or Shire Children's, or even, the communities that surround places like Millard, Fillmore Suburban, or DeGraff Medical Park. So I think it's being a good steward of our assets and making sure that we're a good neighbor and slash good community entity.
Mm-hmm. And I'm just curious, and I know a lot of people are curious. How do you develop partnerships such as working with the Bills, or the Sabres, or our different partners? How are those type of partnerships developed? Because they definitely benefit the community. They definitely benefit the community.
Yeah, so I mean, traditionally, both of the professional sports teams here, even the Buffalo Bisons, have been generous with their time and with their players when it comes to working with the hospitals and our patients. So, yes, Josh Allen's very active at Children's Hospital and does a great job of, lending his name and his brand to that hospital to help raise money, to bring awareness to the hospital. But you have players like Greg Rousseau from the Buffalo Bills, who spends time at both Buffalo General, Suburban. I've been with them at, visiting nursing association, meeting with the staff there. So I think part of it is the organization's belief that they need to give back to the community, and what better way to partner up with, hospitals and workforce there to make sure that they're able to make an impact. And whether the team's winning or losing, I think more importantly, it's how we're helping our patients or our employees, handle what they have going on at that time.
Mm-hmm. Yeah, and it's just it's as to take it from another commercial, it's huge. Our
Yeah,
role
totally.
our role in the community. Um uh and we're going to talk about your legacy in a second, but let's just talk about the employees. In your 20 years, how have you seen the organization? Well, first I want to say, when you started 20 years ago, what was your title?
Came in as the Director of Public and Media Relations.
Public communication. So within that, and I know you've had a few titles since. But the employees, as you're leaving, how have you seen? I mean, employees, have they changed? Have they, are they the same type of employee as 20 years ago, or the needs of employees? I know COVID changed a lot of things on how employees viewed the workforce. What is your, what have been your observations on the employees?
Yeah, I think for the clinical workforce, what hasn't changed is, the commitment to patient care. People that choose to become a nurse or a physician or, a CNA, that takes a special person. That's someone that, really wants to help, right? So, for our workforce, I haven't seen that change in terms of the commitment to our patients. That takes a special person to do that. For the non-clinical employees, sure, COVID changed a lot of things. There is a belief and understanding that people want a more flexible work environment. They want to be able to work remotely from time to time. And I think technology has helped facilitate that. I think just overall, generally, I think, when you look at our workforce overall, it's a tremendous commitment. And really it's an honor to be able to, be involved in an organization like ours, that is entrusted to take care of the community. I'm not a clinical person. I don't scrub in on surgeries. It's to help our workforce, get the resources that they need to make sure that their story is being told and to make sure that, they are ready to take care of our community.
How about the IT? I know my observation, the IT team has grown tremendously. And let's talk a little bit about IT and the workforce and healthcare.
Yeah, so I think all the advancements with technology and information technology, particularly in the hospital and the healthcare setting, have been pretty well documented. Um, so people's ability to gather information, people's ability to gather remotely in a quicker manner, I just think makes everybody's job just a little bit easier. So you're not juggling schedules, you're not jumping into a car 2 or 3 times a day to go to meetings. So there's both the clinical and non-clinical aspects of technology. The move to the electronic health record. I try to explain to people when, people say, I don't understand what the big deal is. Well, if you're in Buffalo and you travel somewhere and you go get money out, your money travels with you. You use the ATM machine. Right now, unfortunately, whether you go from Buffalo to a different hospital that's not a Kaleida hospital, or you go from Buffalo to Rochester, Buffalo to Florida, your health record does not necessarily travel with you. And that's something that our organization and that our industry needs to do a better job of making sure that we accomplish. It's just as important as your bank account.
Hmm. True. And I know even now sometimes when I go to the doctors and they'll ask me what medication, what are the medications that you're taking? And I know electronic medical records is huge. I know a lot of the hospitals, I don't even know how the system works. But a few times I've asked them, I'm like, well, I know it should be there in the electronic medical records. Can you check? And nine times out of 10, it is there because I know how much time, effort, talent, money has gone into electronic medical records. And when they work, it's a great thing because you, as a, it'll be to the point like your money traveling or traveling with you. That's what you're saying. That's what the goal is for electronic
Yeah,
medical records.
yeah. I mean, you can go anywhere really in the world with your ATM card and you'll know down to the penny how much money you have in the
Yeah,
bank, right?
right.
It should be no different for a physician or nurse to be able to log into your electronic health record and know exactly what medications you're on, last time you were at the hospital or a doctor visit, various treatments that you've been through, um, different procedures that you may have had. So that I think overall is an industry and as an organization, like I said, we have to be better about that. I think, in 2025, you'll see more of Kaleida's push to unify the community with the electronic health record.
Yes, yes. Now the tough part of the program. We're going to talk about you. Mike is very humble, and to see Mike Hughes, you wouldn't know that he's what was the hockey where you help raise money for
Yeah,
cancer?
yeah, the 11-day power play. We played hockey for 11 straight days and raised $2 million. Guinness Book of World Records.
Yeah, I mean, this guy who, and I'm going to say, you are a chief administrative officer. What does that mean? Here you are playing hockey for 11 days, raising $2 million. Guinness World Book of Records has nothing, it does have to do with healthcare, but not directly with Kaleida Health. So, chief administrative, what is your role?
Yeah, it's funny you ask because even my wife says, "What the heck is a chief administrative officer, anyways?"
Right.
Um, Really, it's a title that encompasses, the various areas of the organization that I've been, blessed to oversee. So it's essentially all of our non-operations functions. So it's marketing, communications, government affairs, grants, planning, construction, real estate. So all things that are non-day-to-day hospital operations, but that are important to the organization and what we do in the community. So, yeah, maybe a fancy title, but really is just it's overseeing an incredible handful of teams who do important health.
Yes. And so what are some of your most memorable um 20 years? So if you were to say your first, I don't know, 5 to 10 years, your first, let's go down the memory lane of Mike Hughes at Kaleida Health and some things you would like to that you have been part of and you'd like to give yourself a pat on the back. It's okay to pat yourself on the back.
Yeah, that I will never do because, my job is to make sure that, my team has what they need and that they are able to do their job. So, yeah, and it is fun to take a look back because it is remarkable what the organization and our teams have accomplished. And if you just start with physical buildings, we have either expanded or built brand new facilities for every location. So, the VNA, we start there. There's a brand new VNA headquarters. We consolidated 3 locations and built a new facility for them. They have tripled their workforce, maybe quadrupled their workforce in my time at Kaleida Health. DeGraff Medical Park, we transformed that location from an outdated inpatient facility to a modern emergency room with a very robust ambulatory offering. Buffalo General. We have redone the tower itself and we built the Vascular Institute. So we closed Millard Fillmore Hospital and built a world-class vascular center. You go to Millard Suburban, we've doubled the footprint and modernized that facility with new operating rooms, a brand new emergency room. We're in the process of building out a new ambulatory building in the back of the campus. We've added hospitals, Olean General, Bradford Regional Medical Center. We have a partnership and we're building a new hospital down in the Dunkirk, Fredonia area for Brooks Memorial TLC Hospital. So I think from a bricks and mortar perspective, that's been pretty humbling to go back and look on because the physical plan of Kaleida was much different when I first started back in 2004.
No, it definitely was. And VNA is a visiting nursing association. I always like for make sure that I go back with the acronyms. And so so as manager of workforce development, the other day I was speaking with a group of high school students, and the high schooler, the student senior in high school, said he wanted to work in real estate. Didn't see how, real how hospitals could tie into real estate. But as I always tell especially the students I speak with, you can't name one career that healthcare does not offer. And you just talked about real estate, right? Isn't that would be real estate?
Correct, correct. Yeah. So to your point, no one really thinks about it. You're a hospital system. What do you have to do with real estate? Well, we're both a organization that leases space, but we also rent space out. So there are physician practices that will rent space from us. and we're the landlord, they're the tenant, and vice versa. There's real estate that we lease from, whether it's a private developer or organization. So some of our ambulatory locations are leased space. And then there are spaces within our hospitals where we will, or there's physical buildings that we own that we lease space to various entities. So yeah, when an organization our size, the real estate function is very large. We have close to 200 different leases that we're responsible for. And when you look at our physical footprint, it's probably approaching 5 million square feet. Pretty remarkable.
I didn't ask how many employees. We used to always say Kaleida had 10,000 employees. Hasn't that number grown since
Yeah,
2004?
yeah, we're up to close to 13,000 when you add the seven-tier hospitals that we brought onto our platform, and the growth of General Physicians PC, which is our captive physician network.
Yes,
Yeah, we're
yes.
hovering around the 13,000 mark, which is remarkable. It makes Kaleida the largest private sector employer in Western New York.
It is. And you know what? And people always ask, how long have I been here? I've been here 20 wonderful years. I've learned so much, grown, look forward to I'm excited about this year's goals, my personal goals at Kaleida, but in the overall goals, I mean, that whole part has changed also. How we now work, and we've always worked in teams, but now we have what are called team goals. I don't want to segue. We have about a minute left. I want you to have the closing remarks, Mike.
Yeah, well, first, Fran, thank you, for all that you do and utilizing, venues like this to help spread Kaleida's message and the importance of the things that the organization does in the community. You are a true asset to the organization. You are a leader in the community. And, for me, it's been, an honor, privilege, not just only to work with you, but to call you my friend. We've worked together for 20 years, but we've known each other for probably 25.
Yes,
So I thank you
yes.
for that. You mentioned legacy. There's no legacy for me other than the people that have come to work for us, people like yourself and Joe Lepsch and Joe Cascio, Kristen Bieber, Jackie Bett, Rob Bragg. When I look back over 20 years, it's the teams that we built and the work that is going on today. So I don't take any victory laps other than, it's a great team that we have that really has stuck together and really done tremendous things over these 20 years.
Well, on that note, thank you so much, Mike. And I want to thank our listeners for listening during the 2024 year to the Great Lakes Health radio program. And God be willing, as I always end each program, I'll see you on the second Saturday in January, beginning at 7 a.m. Thank you, listeners. Thank you, Mike. God bless everyone and have a great and safe holiday. Bye bye.